On behalf of the Engelberg Center for Healthcare Reform at Brookings, I'd like to welcome you to this event on the path forward for Medicare physician payment reform. We all know that there is a lot of focus right now on the Affordable Care Act. What happens there obviously matters a lot for the future of health policy in this country, but physician payment in Medicare is also a very timely issue, one with major consequences for the well-being of Medicare beneficiaries, major consequences for the federal budget, and potentially major consequences for innovation in our healthcare system, and particularly for whether and how physicians, nurses, and other clinicians will be able to lead the way in implementing the changes needed to address the core challenges of quality, affordability, and availability of healthcare. It does seem pretty clear that clinician leadership is needed. The American public is understandably skeptical of approaches that would reduce the cost of Medicare because of concerns that Medicare cuts could restrict access to needed care. And that's probably one reason why the federal health care programs, including Medicare, have been much less affected by sequestration and other budget reduction efforts than other federal programs. People in the government, in the Congress, and the administration know that the concerns that the public have about the quality of care in Medicare is a very top priority. At the same time, though, rising Medicare costs are making the program difficult to sustain. The history of rising costs is what led to the Sustainable Growth Rate, or SGR, formula for physician payment in the first place. That payment system seeks to control Medicare spending growth by adjusting payment rates in Medicare's fee-for-service program down when physician spending on physician-related services grows faster than the economy, as measured by GDP. Since 2001, Medicare physician spending growth has significantly outpaced GDP growth, with the result that the SGR formula is again calling for a major across-the-board reduction in physician fees, 24% next year. This isn't going to happen just like it hasn't happened in previous years. But it's also become clear that the usual last-minute fix to head off the SGR fee cut doesn't really fix the problems of rising costs and gaps in quality of care in Medicare. The past SGR fixes have caused real problems. Physician payment fees have been squeezed down. Payments have not kept up with inflation. The reductions make it harder for physicians to make ends meet in practice and make it harder for them to spend time with patients or coordinate care or take other steps that are poorly reimbursed. And these payment reductions also encourage greater volume and intensity of services. They present a barrier to innovation because it's hard to add funding for new kinds of services in a time of rising budget pressures. The increasingly tight payment rates make it hard for physicians to take steps to improve care and lower overall health care costs, like using health information technology or care coordination or preventive services or spending time with patients. And the repeated congressional debates about the fixes and how to pay for them suck up the oxygen needed for real reform and create a lack of predictability for other health care providers. As physician efforts are channeled into just preventing the cuts from becoming larger rather than leading the kinds of reforms in delivering health care that could improve quality and lower cost, physician leadership is diverted from where it's most needed, improving care for patients. All of these problems are pretty typical problems for fee-for-service payment systems, which are not a good fit for the increasingly personalized, prevention-oriented health care that progress in genomics, in information technology, and in many other biomedical sciences is making possible. So today, we want to talk about a different path forward, one that provides more support and also more accountability, more opportunities for physician leadership in implementing reforms in care to improve quality and lower cost, which seems like the best way to approach controlling costs in healthcare in a way that would be sustainable. The payment reforms we are focusing on today are ones that try to align payments with better care for patients. Instead of paying more for more physician services, moving to payment systems that, at least in part, pay more for better care that has the potential to lower overall cost. This includes more support for preventive services, more support for effective and efficient care for chronic diseases, more support for care coordination, more support focusing on the needs of individual patients that may not fit into the traditional Medicare fee schedule, and many other steps made possible by innovations in the way that physicians can deliver care. This isn't easy when we don't have the luxury of simply paying for lots more care. It means overcoming challenges like measuring the quality of care and providing new kinds of data to clinicians to help them improve overall care for a patient, and finding the best ways to shift payments from supporting greater volume to supporting better care. We've been working on this in several major initiatives here at Brookings. The Richard Merkin Initiative on Payment Reform and Clinical Leadership, and our Bending the Curve program on changing the way that we finance and regulate healthcare to focus on better care. And Congress has made some remarkable bipartisan progress to implement these kinds of ideas. I want to briefly highlight the two major congressional proposals. They have a lot in common. One is from the House Energy and Commerce Committee, and another is co-sponsored by members of the House Ways and Means and Senate Finance Committee. For more details, I'd encourage you all to take a look at the recent analysis from our group at Brookings, available online at Health Affairs and on our website here at Brookings. The path-breaking Energy and Commerce Committee legislation was passed with strong bipartisan support. It ends the SGR. It provides new payment incentives for physicians to shift from fee-for-service payments to payment systems that focus more on quality and not just volume and intensity. We'll get to hear more about this bipartisan framework and the opportunity to build on it from here in payment reform from our lead keynote speaker this morning in just a few minutes. The Ways and Means and Finance Reform Framework, released more recently, has two major elements that similarly aim to accelerate the use of payments related to quality, better care, and to get to sustainability and predictability of payments for physicians. The various adjustments in the current physician fee-for-service schedule related to quality would be consolidated and integrated into a value-based performance program beginning in 2017 in this proposal. This is intended to create a larger, clearer set of payments for physicians who are taking steps to improve quality of care in their practices. It is still a multiplier, though, on fee-for-service payments, and we've described how these payments could be decoupled from fee-for-service to avoid the tension of focusing on quality on the one hand, but then still paying more when volume and intensity go up on the other hand. This new framework also includes a path away from fee-for-service into alternative payment systems like bundled payments or other accountable care payments that are focused more on better quality and lower costs, through significant bonus payments, additional payments to physicians to help them make the switch, to make the investments they need in their practices to succeed under these new kinds of payment arrangements. Eligibility for bonus payments requires a substantial part of payments to switch to these alternatives to fee-for-service in the next few years. 25% of Medicare payments by 2017, up to 50% after that, and other payments outside of Medicare expected to shift as well. This may seem like an aggressive time frame, but there has been accelerating activity around payment reforms in private health insurance and in Medicare pilot programs today, and because of the congressional attention to this issue, that's helping create even more momentum. The congressional proposals take steps to support clinicians in using these new payment systems through developing better quality measures, encouraging the use of electronic health records to coordinate and improve care, promoting transparency, and helping clinicians get the data they need to improve to avoid patient complications and improve practice. To achieve a broad consensus and push these proposals forward, SGR reform could include a requirement for Medicare to implement a core set of key quality and cost measures that are practically relevant and outcomes-oriented, that are meaningful performance measures for patients. These measures could gradually replace the many process-oriented measures currently used in Medicare physician reporting systems. And also, instead of trying to endorse a large number of process measures relevant to particular specialties and to try to keep them up to date, CMS, with assistance from outside groups, could rely on these expert and diverse quality improvement systems to support performance improvement and improve care in a range of different physician practice settings. The reform proposals could also build on steps that CMS has taken to share patient data with healthcare providers in some of their payment reform pilots and in the Medicare Shared Savings Program. So in this legislation, there's a lot of progress, but there are some challenges ahead, and time is short. One key challenge is how to pay for these reforms. The Congressional Budget Office is likely to estimate that the cost of these reform proposals will be around $150 billion or more over 10 years. That includes replacing the SGR with something like a 0% update over the next 10 years, plus the additional costs related to those bonus payments for participating in alternative payment systems and the cost of the support for the quality and data system improvements that physicians need to succeed under these new models. So one key issue is, what's the best way to offset these costs? It's important to know, in thinking about this question, that Congress has had to find about $150 worth of pay-fors to do the short-term fixes year after year over the past decade, usually by spreading out the payment squeeze on physicians onto other healthcare providers, and that results in the similar kinds of problems as what we've described here for physicians. Well-developed ideas that could pay for SGR reform include reforms in other Medicare payment systems that reinforce the same movement away from fee-for-service and into more beneficiary-focused payments. For example, Medicare payments for post-acute care vary substantially based on where the patients are treated and the intensity of the service, rather than the needs of the beneficiary or the value of the service. Reforms in Medicare benefits and Medigap could reduce Medicare costs without increasing payments by beneficiaries, giving beneficiaries more opportunities to save when they take steps to get the best care at the lowest cost. Well, this is all occurring in the context of the Congressional Budget Office lowering its 10-year estimates for the cost of eliminating the SGR and freezing physician payment rates from $245 billion last year to only around $140 or so billion this year. And that's a reflection of a recent slowdown in Medicare physician and Medicare spending growth generally. That opportunity is not likely to be there for long, and in any case, costs, if Medicare doesn't reform payments, are expected to continue to grow, and as a result, physician payments are likely to become even more squeezed in the years ahead if there's not more significant reform action. So that's one big challenge. Second big challenge I mentioned is the timing. If this long-term reform package doesn't come together, it's possible to imagine at least some interim steps towards implementing this bipartisan reform framework as an alternative to just doing another short-term payment fix over the next couple of years. So today we want to take stock of where we are and chart out the best path forward. We're very pleased to have with us speakers and panels of policymakers, senior thought leaders, and active leaders in the legislative process who will discuss the recent congressional proposals and the options and the opportunities for moving forward. Before we begin, I want to emphasize that this is a program where we want your participation. We'll have some specific opportunities for questions and answers from all of you at various points during today's discussion. So we'd like you to hold your comments and questions till we get to those points, and we'll have a microphone available for you to use to make sure that everyone can hear you. We're on the record today. We are being joined by media. This event is also being webcast on our Brookings website, so everything today is on the record, and I'd like to get going right now. To begin with, we're very honored to be joined by Dr. Michael Burgess, a leader on the House Energy and Commerce Health Subcommittee, in fact, the lead sponsor of the Energy and Commerce Passed Physician Payment Reform Bill, and a longtime advocate of Medicare reform that focuses on supporting physicians and focuses on providing better care at a lower cost. He's going to make some remarks on the issues that I've just described. Prior to his leadership in Congress, he spent nearly 3 decades practicing medicine in North Texas. He served from the 26th Congressional District in Texas since 2003 in the House of Representatives. And I'd like to welcome right now Dr. Burgess to the podium. Dr. Burgess.
Well, thank you, Dr. McClellan. You know, as we approach the end of this year and everyone's asking what's going to happen, I'm reminded very much of a time not too many years ago in 2005 when the Deficit Reduction Act was going through the House and the Senate. It contained within all of the other verbiage a doc fix, and didn't quite get done by the end of the year. The House and the Senate, as you may recall, passed different versions, and those had to be reconciled, but hey, the House had gone home, they weren't coming back, the Senate wouldn't see the House's change. So we essentially busted through the deadline, January 1st. It was probably January 5th that Dr. McClellan put my cell phone on call block. I didn't even know you could do that, Mark, but he got tired of hearing from me. That just points up, and we're, here we are careening toward the end of the year again. We marked up a bill in the Energy and Commerce Committee in July. I was informed literally on the way in here that Senate Finance has posted a markup for December, which is going to push us pretty close to the deadline, and that's once again a very uncomfortable place to be. Just so I know the audience, for those of you who are physicians, would you raise your hands? Okay, they're not nearly enough of you. One of my great fantasies is I'll walk into an Energy and Commerce hearing one morning, and there'll be 5 doctors at the witness table, and we'll have a hearing on how to pay economists in the future. I'm really looking forward to that day. Of course, Dr. McClellan could do double duty that day. And I'll also be honest with you, 12 and a half months ago, I actually predicted a different outcome to the election, and I was getting to the point that I thought this SGR problem is just insurmountable, but perhaps in a fully mature premium support system, it will become irrelevant, and we won't have to have this discussion anymore. And then the election turned out differently from what my prediction had been. And I will confess to you that during the month of December last year, I really wondered, well, whither the SGR, because how do you solve this problem? Well, I was saved by the Congressional Budget Office. They came riding into town on their white horse in January and said, we're putting the SGR on sale. We had some hearings about that. We invited the MedPAC folks in and said, what in the world is going on here? And they said, So since they didn't know what caused the cost to come down, no one could assure us with any certainty that it wouldn't go right back up. It's possible that it could come down. I have my own theories on why the expenditures in Medicare were less and the projections were less. I think Dr. McClellan actually has earned a great deal of credit in that regard. I think his efforts on the Medicare Modernization Act, this Friday will be the 10-year anniversary, or is it early Saturday morning? I never can quite keep it straight, but the end of this week will be the 10-year anniversary of the passage of the Medicare Modernization Act on the floor of the House. Those of us who voted in favor of it argued at the time that, look, the timely treatment of a disease with a pharmaceutical will offset some of the costs of paying for the hospitalization of the surgery. You use more statins, you're going to pay for fewer heart attacks. You treat more diabetes and control blood sugar better, you're going to pay for fewer dialysis treatments or fewer leg amputations. And that seemed to make sense at the time. I don't have the data to support this hypothesis, but I'm a member of Congress. I don't really need data. I just need a hypothesis and an audience and be able to articulate it. But since Mark was one of the drivers on the Part D of the Medicare Modernization Act, I think HHS and CMS do deserve some credit for that, because I think we are beginning to see the benefits that 10 years ago many of us imagined might occur. But I don't know why the cost went down, and I do worry that at some point someone will recalculate, say, oh my gosh, we missed a zero there, and up will go the cost again, and the opportunity will be lost, which is why I really have pushed the committee and pushed staff to let's do something meaningful this year. But it actually goes back longer than just this year. It actually goes back to a previous Congress where again, the commitment of the incoming chairman, Fred Upton, to this issue, the commitment of the majority leader, Eric Cantor, and Speaker Boehner to this issue of getting this resolved was clear and palpable as we began the congressional session that began in January of 2010. So this work has been ongoing for some time. Sure, all the oxygen went out of the room with the Supercommittee a couple of years ago, and everything came crashing to earth, but all of the background work was not lost. And I do want to credit the committee staff, John O'Shea, who's now here at Brookings, and my personal staff, J.P. Poliskevitz, who you'll hear from on the panel later on, really burned the midnight oil on this. They set up an email where people, doctors, patient groups around the country could send information to us. I cannot tell you the number of times I was out doing something unrelated around town and someone from the neurosurgeons or someone from the orthopedists would say, I was really upset by what I saw going on, but I got to say, I sent those comments in and I was pleased to see that they were taken into account. That type of collaborative building from the grassroots up rather than a top-down approach, I think served the committee well. On the last day of July, the committee did mark up and pass on a bipartisan fashion 51-0. Every member who was present that day voted in favor of H.R. 2810 and to move the bill along. And this was a bill to repeal the sustainable growth rate formula, 5 years of stable updates, 0.5% inflation adjustment. The next 5 years, there is a potential for quality adjustments upward. There is also the possibility of a quality adjustment downward. One of the problems of being you put your bill out there first, and it's great. You get credit for the leadership. You get credit for breaking the log jam, and that lasts about this long. And then you start catching all the javelins, the pent-up demand. Let's be honest, doctors are angry about the way they've been treated by the federal government, the United States Congress, the federal bureaucracy. Many of them are looking for the exits. And one of my principal drivers was we got to stop that move to the exits, because one of the missing links in the Affordable Care Act was dealing with physician shortages, physician manpower. They didn't do it. There were other missing links in the Affordable Care Act, and we could go into that in some detail. In fact, I'm prepared to do that if you'd like. But nevertheless, one of the missing links was physician manpower. I talk to groups of doctors all over the country, and I get the same thing. I can feel the heat. I'm trying to see the light, but I do feel the heat from those doctor groups that we don't like the way we've been treated, and we are so angry that it is possible that we won't be there next year. You hear it all the time. People can't find a physician who will take their Medicare. I want to stress, when I was in practice, I always did. I never closed my practice to Medicare. My mother told me I could not, and that it would embarrass her at the golf course if one of her friends called my office and said, we don't take Medicare patients. So I never did that, but I'm not in practice anymore, and I haven't been in my office in 10 years' time. A lot of doctors around the country are having to make a very difficult decision. You're not reimbursing me for the cost of delivering the care. This is one of those things, if you're losing a little bit on each patient, it's hard to make it up in volume, and they are making a rational choice, an informed choice, that this is a part of their practice that they will have to move away from. I wanted to stop that. Now, a lot of people argued with what I did, was saying, hey, we need to get the elimination of fee-for-service. Fee-for-service is an anachronism. It should no longer exist. You talk to a group of doctors my age and tell them that they will no longer be able to see patients and bill the way they've always done, they are checking out mentally. I have seen bundled care work one time, right after Katrina. East and West Jefferson Parish hospitals said, our medical staff is in agreement. If you will give us money, they will trust us to distribute it to them. So a storm of biblical proportions where all of your accounts receivable is in the bottom of the Gulf of Mexico. Bundled care may look like a reasonable solution, but for most people out there, I'm going to trust my hospital administrator? I don't think so. I never have in the past. Leave me the ability to see a patient and bill for that service. So that's what H.R. 2810 does. It allows fee-for-service to remain. It allows a 5-year period for stable updates. The reason 5 years was selected, I know Ways and Means had a different idea about that, but honestly, this was feedback from the Center for Medicare and Medicaid Services. In order to move to a new paradigm, it is going to take time. Where have we seen that recently? It will take time to program the computers and to do the things that you're asking us to do. 5 years of stable updates does not seem unreasonable. I do get criticism from doctors who say, well, look, stay out of my life. I don't want new performance metrics. They're coming anyway. The PQRS performance requirements are going to be there anyway. And the ones that we have incorporated into HR 2810 simply build upon that which is already coming. With all deference to Dr. Mostashari, we did not deal with the meaningful use reduction that's coming at 2810, and I have gotten some criticism that I haven't dealt with that aspect of aggravation in doctors' lives. My answer is I can't take care of all of the problems at one time. Now, what do we see happening before the end of the year? Senate Finance is now going to mark up in December. I don't want to patch. I will just tell you, we've worked on this, we've patched this thing long enough. Dr. McClellan stated it very eloquently. I got the CBO score on HR 2810, and it predicts $175 billion over the next 10 years. Boy, that seems like a lot of money. But in what year, when we have patched the SGR, have we spent less than $17.5 billion? So over a 10-year budget cycle, I would submit we've spent much more than that. We can repeal the problem and get it out of our lives, get it out of our doctors' lives, get it out of our patients' lives, spending the exact amount of money that we're going to spend on patches over the next 10 years' time. One of the criticisms that I have gotten is the bill, HR 2810, did not have pay-fors built into the bill. You know, I got a piece of advice from Bill Thomas many, many years ago. I had an SGR repeal, and I took it to him and I said, Chairman Thomas, I would really like your opinion, even though I was on Energy and Commerce. I said, I'd really like your opinion of what you think of this SGR repeal that I've cobbled together. And he starts reading through it, and he said, oh, what do you have against these guys? You don't like these guys? They've been pretty helpful to us. Well, his point was, you don't throw your friends under the bus until the end of the parade. When we are ready to actually meaningfully move this, sure, I got pay-fors in the back of my mind, but at the same time, it is counterproductive to discuss those today. And we all know what happens when you put those forward. Everyone gets nervous. As Chairman Camp found out, everyone gets nervous. You put forward a blank piece of paper and said, this is our tax reform. We're going to build on that. And of course, everybody feels that their tax deduction may be at risk. With this approach to an SGR, everyone feels that, hey, I may be the target for a pay-for. So it does create a certain amount of anxiety around town, but I consider that constructive anxiety because people come forward and say, look, you know, one of the things you could do. So we've actually received suggestions from people around town and from various aspects within the healthcare sector, and I think that's a positive thing. People are actually actively engaged and working on solving the problem. The fact of the matter is this. With the Affordable Care Act, there is not the physician manpower to do everything that the nation's doctors are going to be asked to do. If you don't fix the SGR, there are a certain number of doctors of a certain age who, again, are headed for the exits. I see HR 2810 as an effort to keep those doctors engaged in direct patient care, keep them involved in seeing their patients. Their patients are, in many cases, our mothers, our fathers, or ourselves as we all age. We know that there is a volume problem in Medicare, but the volume problem is not dictated by what your doctor's scheduler puts on his work day. The volume problem is dictated by the 10,000 people a day who are entering the Medicare system. You cannot tackle the problem from volume alone. You have to tackle it on the standpoint of are we going to make the commitment to these patients who have paid into the Medicare system their entire lives? Are we going to see that commitment through, that promise that we made? Are we going to fulfill that promise? Restricting volume may be useful in some settings. In this setting, I think it's going to be counterproductive. That is right at the time you told me, so I'm going to stop there. Dr. McClellan said we would have time for 2 questions as long as they're true or false.
Or a little bit longer. Thank you very much, Dr. Burgess. Any questions from those of you who are here today? Let me ask one while we're warming up here, and that is, you mentioned the markup scheduled in Senate Finance coming up soon. Assuming that goes through, how do you see things unfolding from there? And will the action come back to the House, and how do you think your bill will get integrated into this process?
Well, I did tell you that I'm not in favor of a patch, and in many ways we patched how many times, and a patch would look a lot like the opposite of success to me. However, we need the Senate to act. I mean, part of my fantasy is having doctors decide how much economists would pay. The other part of my fantasy is we would pass H.R. 2010 as a standalone bill through the House and Senate, and I'd be carried through the streets on everyone's shoulders. But I know it ain't going to happen. I need the Senate to do something. I need them to act. I wish it was before the second week of December that they would have their markup. I wish the House wasn't going home on December 13th. This is all creating a great deal of strife and anxiety, which, in my opinion, is unnecessary. If a patch is necessary to get us to the actual solution to this problem, as long as we're moving in the right direction, I won't say no to a patch. If we're doing a patch for the sake of having a patch because we haven't done our work at the end of the year, again, that's the opposite of success. But the next step cannot be taken unless Senate Finance marks something up. I mean, I can't go back and renegotiate H.R. 2810 with the Energy and Commerce Committee to get something that's more like the white paper that was put out by the Senate. You know, the task of getting legislation to the Energy and Commerce Committee, and John O'Shea will tell you, it was not easy. It encompassed 2 sessions of Congress. It meant that we talked to Democrats on the committee, and when does that ever happen? But their counter to us was, we're nervous about you guys writing legislation. Maybe we'll do a white paper with you. And our position was, we're writing a bill. You're welcome to be in the room or not. They stayed in the room. They came back. They stayed in the room. It meant that many of us had to leave our weapon of choice at the door because it meant that the other side was not going to continue. But the talks were progressing, and they seemed to be producing a real product. And at the end, we have a policy that was agreed upon in a bipartisan fashion on repealing the sustainable growth rate formula. I mean, in the 10 or 11 years that I've been here, that had not happened. And in fact, that was referenced during the markup that morning. Chairman Waxman, Chairman Dingell, Chairman Barton, all of whom had been chair of the Energy and Commerce Committee at different times, said, I tried to do this and I couldn't get it done. But today we're actually moving forward. People can argue that it was an incomplete product because the pay-fors weren't included, but again, at that point, it felt important to me to get the policy right and worry about the pay-fors later. There's plenty of places in all of the money that the federal government spends in healthcare that the pay-fors can be found. And again, I would just stress, we're not really paying any more for repeal than we've paid for patches every year, year in and year out over the last 10 years. Had this approach been taken when I first got here in 2003, we would probably be talking about vaccines or something this morning. We wouldn't be talking about the SGR.
Well, we'll have you back for that event as well. Any other final questions from the audience? Let me just ask one more thing, Dr. Burgess, if you got one more minute. So there are some physicians in the audience, as you noted, more participating online, and then a lot working with us in our clinician leadership initiatives here. Any final thoughts for them about how they can move from, assuming this legislation gets through, how they can move from frustration and heading for the exits to taking advantage of the bonus payments and the opportunities for doing something different for their Medicare beneficiaries?
Well, one of the things I've sort of learned through this process and talking to a great number of people and getting a lot of input is that the Medicare Advantage from 10 years ago is actually working better in some markets than I would have ever believed possible. And Medicare Advantage programs that fully developed electronic health records, disease management, care coordination, use of extenders, All of those things are working well. The doctors in those practices are satisfied. They feel that they're well compensated, and they've certainly moved away from what I would have considered the gold standard, which was a fee-for-service practice of medicine. So certainly I know that it is possible, and it is within the grasp. At the same time, and I make the point all the time in the Energy and Commerce Committee, if everyone is pushed into an ACO type of model, I've got nothing against an ACO type model. I think Secretary Leavitt, when he was at HHS with the Physician Group Practice Demonstration Project, although there were difficulties encountered, there was a lot of enthusiasm from the doctor groups that participated in that, and I think an ACO model could work well. But the doctor in Muleshoe, Texas, he's just one guy. You can call him an ACO, you can call him anything you want, but he's just one guy. He's not going to have an ACO type of practice, and for that reason, we need to allow that family practitioner in Muleshoe, Texas, to continue the practice that he's always had. Otherwise, he will get frustrated and decide that it could be perpetually deer season somewhere around the world, and off he goes. And we will lose that individual as far as a practitioner is concerned.
Dr. Burgess, thanks so much for joining us this morning, and good luck in the busy month ahead. Thank you.
Thank you, Mark.
Thank you.